Okay, good morning. I apologize for starting a little late. It's typical Monday morning, and I apologize also for my lack of childcare, but I figure if there's any meeting I could attend at the legislature with a small child in tow, it's this one. So this is Beverly, and I see some other kids here, so we're not alone with the children. Welcome. My name is Stephanie Stuckey-Benfield. I'm one of the co-chairs of the Direct Entry Midwifery Study Committee. Oh, there's another baby. Yay. The other co-chair is Representative Mabel Thomas. She is at a press conference at City Hall right down the street, and she is coming here as soon as that ends. And she and I may have to do some tag team where she'll take over chairing duties when she arrives because I have to leave early today. Let me introduce the other committee members who are here. We've got Dr. John Schilling, who's joined us. And if you wanted to say a little bit about your practice and where you're located, that would be great. And we do have to cut these microphones on. This is being webcast. The camera's over there, so you can smile on the camera. And you have to cut your microphone on when you speak.
I think it's, yes, okay, it's on. Good morning. I am a locally born and bred Georgian, and had all my training in the state of Georgia and returned here back in 1988. And as I was telling some of the other committee members, down in Henry County where I practice at Henry Medical Center, I was the first physician who brought regular licensed midwives back to hospital practice. And over the past 18 years has had as many as 4 midwives working in our practice, nurse practitioners and otherwise. Currently, approximately 1 year ago, I left my large group and went back into solo practice. Main reason was to slow down the obstetric side of my workload, but the midwifery protocols are still in place. But one of the reasons I'm on the committee is I guess I'm one of the few physicians in the state of Georgia who actually goes ahead and sees many of the patients who are taken care of by some of the certified midwives outside. I will see those patients so that in the event that they have to be hospitalized, they are at least come under my care. And they see me anywhere from 1 to 3 times during the pregnancy, and they are allowed to choose any services that they want. And we just charge them per visit, and it works out very well. And I think that in my 18 years of doing that, I think I've had about 5 people actually have to deliver in the hospital, from probably over a couple of hundred women that choose that outreach. And so, although I'm slowing down my obstetric career, I'm still very interested in helping out the women of Georgia.
We're very pleased you're taking time out of your busy practice to be here with us. We also have State Representative Donna Sheldon, who was with us last meeting. Thank you for being here. Do you want to say anything, Donna? And Nazra, tell me, Anor, who is one of the committee members and was not able to be with us last week, so I'm very happy she can join us today. And do you want to say a few words? I know you have some handouts for the committee members, and we make copies for other people. Do you have anything you want to say?
No, not really. Just greetings. I'm very pleased to be here. And I'm a midwife, and I've been a midwife since the early 70s. And I remember when the resolution was going in during those times, and I wasn't really interested in how it was moving at that time. But now, at this particular time, then I have more of an interest because of the regulation, how things are being regulated with midwifery and childbirth. So, I'm just here to see how we can have better results with the infant mortality rates that we do have a concern with as midwives. And I just look forward to see what the results are going to be.
Thank you. And last we have Debbie Pulley, but since she will be presenting, I'm going to just wait and let Debbie give her presentation. Just to briefly recap, last meeting we had an overview of midwifery, in general, and then also specifically midwifery practice in Georgia. And today, the agenda, we're going to focus on what other states are doing. There are some 28 states who allow varying forms of midwives to practice home birth, and we will be looking at what the other states are doing. Let me also introduce our staff for this committee, without whom we could not function. We have Sally Fox with House Research, and joining us today is Terry Long with Legislative Counsel, and I'm so happy she's here. She's new to Leg Counsel's office, so it's great to meet her and have her part of our process. Also, one housekeeping note, we have a sign-in sheet right there. At the end of the presentations, we will be allowing people to speak. So if you are interested in speaking, sign up your name and what organization you're with. If you're not with an organization, just put down that you're here speaking for yourself. So with that, we will now begin with our formal presentation, and I'm going to hand the program over to Debbie Pulley. Thanks.
Is that working? Is that working?
Yep, it's working.
Okay.
You may have to talk loud, though.
I don't know if I can talk loud. No. Good morning, all.
Good morning.
I'm Debbie Pulley, and I am a certified professional midwife. I am the president of Georgia Midwifery Association. A few other hats I wear are I'm legislative chair for the Midwives Alliance of North America, and I'm on the board of the North American Registry of Midwives, which is the national certifying body for direct entry midwives. When I'm not doing that, I'm a grandma and a mom and a wife, but and a midwife. So Terry will be pleased to know that my presentation is probably going to be 5 minutes. All right, so I'm going to start out. All the committee members were handed a little bit of homework, as you can see. These are actually the laws and regulations for the states in which direct entry midwifery is regulated. And fortunately, I had already read them, so I got to just play cards online. Where are we? Right now, there's a law in the books that says that direct entry midwives can practice. There's been no new certification since 1979, 63 or 79, depending on who you talk to. Direct entry midwives in this state have applied for certification through the Department of Health, and that's been denied. So Susan and Terry and Debbie are going to be talking about actual practice and regulation in other states. So I'm just going to give you an overview. Let's see if that works. No. That works. When a state has an underground network of healthcare providers, it has a responsibility to deal with the problem through regulation rather than prosecution. There are midwives all over the country practicing. States have realized that. They are now regulating the midwives through licensure or certification, and have realized that the direct entry midwives are autonomous providers. These are the states that use all or part of the norm exam, all or part of the norm process for licensure. And then we have the blue states up in the top right, New York and Rhode Island, use the CM process, which is the direct entry midwifery certification through the American Midwifery Certification Board. The green states, midwives practice without licensure, but it's also exempt from the Medical Practice Act. So in these states, midwives practice relatively freely. They have birth centers, they do home births, they file birth certificates, and the white states are states where it's pretty ambiguous or totally illegal. And you can notice that I don't see Georgia on there anywhere. So what we'd like to see is that Georgia be purple pretty soon.
Can I ask about the green states?
The green states.
About talking in here. The green states where there is an exemption from the Medical Practice Act, that means there's no regulation. There are no regulations on the books governing practice. There's just the law is silent, but they cannot be prosecuted since they're exempt. Midwives cannot be
It's possible
prosecuted.
they could be prosecuted, but so far prosecution hasn't. I mean, no prosecution has been successful.
Okay.
Kansas had a midwife charged, and she was, I believe, this is a few years ago, found guilty, and it was appealed to the Supreme Court, and the Supreme Court issued a ruling stating that, yes, midwives practice, and that practice may include the same things some doctors do, but it doesn't mean it's a practice of medicine, it's a practice of midwifery. And just because a midwife is doing something that a physician's doing doesn't mean that it's a practice of medicine. So that was a nice, clarification for us. Does anybody else have any? Yeah. Actually prosecuted, one or two, and these were midwives who were like church midwives. They weren't necessarily trained midwives, who, in both cases that I can remember, they were ones where it was a religious situation where they were not transporting and praying to, two that I can remember in 27 years. One other one, the midwife in Cobb County. She actually just was given a cease and desist order.
On the Cobb County case, we are getting more information about that. Sally with research is pulling some of that data because I know that's of interest to the committee members since that was part of the Department of Public Health's decision to cease and desist. Am I misstating that?
Yeah.
Okay.
The Department of Health ceased and desisted without any help. They stopped certifying in 1979. This situation happened in 1990. And it was because of this situation that the Department of Health decided to start recertifying midwives. And that's when the task force was put together. And Patricia White was the over that. And the task force was put together, got ready to meet. I think we talked about this last week. And then disbanded before any recommendations could be made. So the deaths in Cobb County, if anything, led to recertification. So, all right, so that's it for mine. Anybody else have any other questions about the states? Susan will go into more details with that. Who do we have next? Susan. Midwife and IT director. Yeah. Thank goodness. Let's see, where are you? Okay, that's you, right? Regular midwives. I can't get mine. So what do I punch? I don't. I can't figure out how we could go, so just punch this. Okay. Okay. Good morning. Wait a minute, that's not right. It's not showing up there. I know, I got it. Yours? Didn't I have your name on it? It's the next one. Oh, okay. Isn't it way too early in the morning? When you're... Oh, there it is. Okay. I hit it till we got it. Okay. Are you going to punch the buttons for me? Or am I going to... It's just the right arrow. Okay.
Is it on?
Yeah.
Yes, it's on. Good morning. Now we've got the technology set up here. I'm going to be talking about regulating midwives, some more details than Debbie presented. just so you know who I am, my biggest hat probably right now is I'm president of Citizens for Midwifery, which is a national consumer-based organization of people that want to promote the Midwives model of care, which is the kind of care, we talked about some last week, that most typically is provided by midwives outside the hospital, but we'd like to see it be the standard of care for how women are treated respectfully and with evidence-based care in all birth settings. So these are some of the issues that I wanted to bring up with regard to licensing. So I'm going to go through most of these in more detail in subsequent slides, and especially with regard to what is done in other states. So I'm not going to read my slides, and the PowerPoint will be available to the committee members with the notes, and if anybody else wants it too. So in the interest of time, I'll just keep going. Okay, of the 22 states, all of them use the NARM written exam for the licensing exam. 4 of those states use the entire CPM process as the basis for licensure. So in order to be eligible for a license, you have to be a CPM. The other states use parts of the CPM process.
Are there any in the Southeast who use the CPM?
South Carolina, Tennessee, Virginia, Florida.
Plus. CPM plus.
CPM plus, okay. Some of the states passed their statutes before the CPM process existed, and then they've retrofitted, and I don't have all those in my head, so that's why I couldn't answer that. The last point, of all those 22 states, only 2 require the licensed midwife to have a formal relationship with a physician. In one case, it's supervision. And I'm going to talk some more about that because that seems to be something that's always brought up, because nurse midwives have to have some kind of relationship with the physician, so why shouldn't direct entry midwives? So I'm going to talk about that some more and why it's a major problem. And also to mention that some of the additional requirements are, like in New York State, they don't use this process, but you also have to have a pharmacology course, because under the midwifery statute in New York, which applies to all midwives, they're allowed to use medicines, prescribed medicines, so they have to have this pharmacology course. But in other states, it might be simply a little test on the state laws that a midwife needs to know what's required of her, the midwifery statute, and maybe some other public health information. So some of these requirements that sometimes are found in the CNM regulations, but are also found in some of the older direct entry midwifery statutes, are really problematic when it comes to can a midwife actually practice, and do women actually have access to midwifery care. And I'm going to talk about these separately. These are several examples. There's probably more that I haven't even thought of. But what these all have in common is they ignore the fact that these midwives are well trained as independent maternity care providers in out-of-hospital settings, and that midwifery is not the practice of medicine, and that obstetricians, that are usually the ones that would be required to supervise, with very few exceptions, are not trained in the midwife's model of care. So you have 2 different practice models, and one is supervising the other. It doesn't work very well. So, yes.
How does that work with the nurse midwives currently in Georgia? Do they have 2 different practice models? The nurse midwives and the OBGYNs?
I'm not myself a nurse midwife, but I certainly have talked with many, and my own home birth midwife was a nurse midwife, so I do know a lot about that, and it doesn't work very well. That's one reason why there's one home birth nurse midwife that I'm aware of in the whole state, and for a long time there were none, even though nurse midwives legally have the right to practice, but they could not. The difficulty is finding what we refer to loosely as a backup physician. And I'll talk a little more about some examples of that. So for direct entry midwives, requiring some kind of doctor backup. We'll just call it backup. It's different in different states, even for nurse midwife, but by backup I mean some kind of a formal agreement between a midwife and a physician. So now lots of midwives have informal things they've worked out with a physician, but I'm talking about a requirement for a formal one that the doctor has to acknowledge publicly at some level. So for direct entry midwives, only in California and Louisiana. Louisiana's statute is, 30 years old when they did it? California's is 12, 15 years old, 10 years old. And in any case, in California, it's supervision. It's not just consultation or referral. It's supervision, which has a legal meaning to it. It was added at the last minute when the bill was being passed. The Medical Association demanded it, and the legislator wanted to get the bill passed, and that's how that got in there. And it's been a huge problem, and I'll talk a little bit about more of that in a minute. But this is also typical of CNM requirements, and it has been used to close out-of-hospital practices and in-hospital practices. Essentially, when you require any midwife to have anything from the physician, and you don't have any requirement for any physician to engage in that relationship, whatever you call it, then the doctor has the power to determine if and whether and where a midwife will or will not practice. So, for example, when a nurse midwife friend of mine, she found a backup physician for in-hospital births. So she was working with this obstetrician, but he had to approve her protocols before he would go into an agreement with her. And he made her change a bunch of her protocols because he didn't like them. So there's that difference between the models of care. But, she worked with that. So she was working, and she had lots of women. They came because they wanted her services, and this guy was in a bunch of insurance plans. She built up the practice. He decided to bring in another OBGYN. He gave her a week's notice, and he turned all those women who were planning to have their birth with the midwife over to the new OBGYN that they had never met before. And most of those women could not change the practice or the hospital because of limitations on their insurance. So that's an example in Georgia of how that happened with a nurse midwife requirement. The bottom line is midwives and physicians are economic competitors. And out of Ryman and Athens, that was definitely an issue. And I was a client who left an OB practice at 7.5 months pregnant and took my insurance money with me, which did not pay for my home birth with the nurse midwife. But there's in the talk last week, I gave you a reference to an article on our website that goes into a lot more about how hospital economics affects what women get from maternity care, and it affects whether they have a choice of midwife or not. And physicians who agree to back up home births, depending on the climate in their area and in their hospital, may be under pressure to not do that. And we actually had an OB, a new OB that was coming to town and had met with the nurse midwives that had the home birth practice and said, "Oh yes, I'll back you up, no problem." And then when he actually went and met with the OBs, and they took him probably to the country club or whatever, then he wrote a letter and said, "I'm not doing it." And they had women that were due in a couple of weeks, and all of a sudden they couldn't legally attend those women because they had no backup doctor.
What are the minimum requirements? What are the minimum requirements for a midwife? Or regulation? We're talking about regulation. What are the minimum requirements for a midwife?
Well, when for nurse midwives, they have to have completed the ACNM nurse midwifery program, which is a post-baccalaureate program, and passed the written exam.
Okay.
For the direct entry midwives, the requirements vary somewhat from state to state of the 22 states. All of them use the licensing exam as a licensing exam, the written part of the CPM certification process. And 4 of them, is that what we said? Yeah, 4 of them require the midwife to be a CPM in order to get licensed. And those tend to be the most recently passed statutes, because prior to the CPM even being available, each state had to create their own process. And it's expensive to do that, and with increasing litigation, it's expensive to have your exam and make sure it's legally defensible. That's why all those states use the NARM exam, because it has been developed and it's been checked and rechecked and meets all the requirements for that kind of an exam. Okay, so this is the second example I've already told you about. The first one was for the home birth nurse midwife practice in Athens, and it was actually not in Macon, it was Monroe. The physician was in Monroe, which was not optimal for backup care, because if you really have an emergency, you got to go to a nearby hospital instead of one, an hour away. But that physician, when he moved his practice to Athens, he quit backing up the nurse midwives. And that was when that home birth practice closed, because all of us clients, we wrote letters, we visited people, we contacted every potential backup doctor in a 40-mile radius of Athens, and nobody would do it. And this midwife was exemplary in her practice, and she met all the, crossed the T's and dotted the I's, and was completely legal, etc., and was prevented from practicing because nobody would agree to back up. And it had nothing to do with her clinical practice or qualifications.
It's written agreement, right?
Written in Georgia, if I am correct, it's a written consultation referral agreement with a physician. And again, in Austin, Texas, 2 hospitals, they just told the midwives they couldn't practice there. One group of midwives was employees of the hospital. The other group of midwives, worked with an obstetrician but delivered babies at the hospital. It was because it was for economic reasons, pure and simple. And in Iowa, there's a nurse midwife with a birth center and a home birth practice, and she met the requirements. She had her backup doctor. The local hospital said, no, you have to have 2 backup doctors. And they knew there was not a second backup doctor in the area. And that's, I believe, is under litigation right now. So she can't, when she has to transport, she can't go in the hospital with her clients. And that was the same situation in Athens when I had my kids. The hospital would not let the certified nurse midwife in the door. And I think it's also important to remember that in all these cases, the women, the mothers, they got potentially harmed by this. And when you look at some of the handouts I gave you last week, that the intervention rates for out-of-hospital births are incredibly lower than what women are subject to in the hospital. So women ought to be able to not be in the hospital. But this system of requiring the midwife to have this relationship does not work for the midwives, and it does not work for the women. Okay, real quickly, this is in California, where there's the requirement for supervision, which is a lot strong, legally it's a lot more than consultation and referral. Not a single licensed midwife. I think there's one who's actually physician's assistant. And so she's got to back up. It's through her being a physician's assistant, not because she's a licensed midwife. So nobody can find a supervision. Malpractice insurers have threatened loss of liability insurance if the obstetrician talks to a woman planning a home birth or a midwife offering a home birth. So they can't get referrals and medical tests are needed. And there's been, I'm a little hazy on the details, but there's at least one baby that died because they could not get the mother a stress test that would have given them information on how to correctly manage that birth and probably not lost the baby. California, they're still working on how they're going to change that language, and the medical board has agreed to not prosecute those midwives for not having supervision, but it's a huge hassle and expense to have had that in the bill to start with. So just to reiterate, when a midwife is required to have that backup, here's different ways that a physician can squelch that practice. And American College of Obstetricians and Gynecologists for many years has held the position that anything outside of the hospital is dangerous and have acted in any way they could to stop licensing of direct entry midwives and keep nurse midwives from practicing outside the hospital as long, when they're not directly under the control of the obstetricians. And this requirement for a relationship with a physician is a really great way they have of making that happen. So here's some points about the economic connection. Every out-of-hospital birth of a midwife is a birth that an obstetrician is not getting paid for, the hospital is not getting paid for, there's not complications that use all the other departments of the hospital. So when the hospitals use an out-of-hospital birth, they see money walking out the door. They see somebody wants to set up a birth center, and I'm not saying this is every hospital administration and every OB is like this, but across the country you see this over and over again. So that's why there's this conflict of interest, and there should not be a requirement. Now that said, I have never met a midwife in over 20 years who did not want a relationship with a physician that she could consult with and refer to. I have not ever met one. So the midwives want those relationships. It's not that they don't want what's best for moms and babies. They want a respectful relationship with the staff of the hospital. They want to be able to transport and stay with the mom and provide the information. It's the system, the way the system is set up, and the economic interests of the system that are preventing that from happening. And requiring it will not, for the midwife, does not work.
I have a question.
Yes.
In your opinion, is there any state that has a model for a relationship between the midwife and a doctor that works, that's formalized in a reg or in statute?
Yeah, a lot of the statutes, and especially the most recent ones, have specific language in the statute that specifically says that when you transfer care to a physician in a hospital, those entities have no liability for any action or omission of the midwife, before the care was turned over. And I think that in a lot of places, I just spoke to someone in Wisconsin last night. Wisconsin just passed a bill, and they got their rules and regs now. They're ready to license midwives. And she said they're getting calls from doctors who were afraid to have anything to do with the out-of-hospital midwives because they weren't licensed. And now they're licensed and it's all laid out. Now there's doctors calling up and saying, oh, we're so glad we can work with you now. So while the licensing doesn't solve everything and it doesn't retrain doctors and it doesn't change beliefs, it does open the door for all those places where there is openness to this. In terms of how you change the belief system and the training over time, that's a much bigger question than one statute's going to address. But this is a step in the right direction.
And I think to answer your question is, there is no statute that says you must do this and you must do this with a physician. It says the midwife must have a backup arrangement made, so that be whether it's to the closest hospital, whether it's with an informal backup relationship, whatever. There's not a specific, you must do this, you must do this. It's just
you
like
each birth.
Each birth is unique, and so is each backup arrangement for each birth. Because we're not practicing out of one hospital. We're practicing all around this,
And I think an important piece of this is, the plan might be call an ambulance to go to the nearest hospital. That might be the best plan. That's probably the best plan that could happen in Athens, okay, for many, many years. So the important thing is that there's informed consent, so that the midwife is up front with her client in the beginning and saying, we don't have a friendly doctor here, and we don't have a friendly hospital here. So here are your options, and the plan, if there's an emergency, is this. And then the client can say, oh, that's terrible. I don't feel comfortable with that. I'm going to go, move to my mother's house when I have my baby and find a midwife there. okay, so that it's very clear up front exactly what situation you're dealing with, because especially in a state like Georgia, it hasn't been optimal for mothers and babies, for a long time. And that's what, hopefully, the statute that would come out of this would move us towards an optimal situation. Yes, Nasra.
Yes. Is it on? Okay. You're speaking a lot about the certified professional midwives, the licensed midwives already.
Right.
What do you have on the direct entry midwifery exemption? You mentioned something about that with states, the midwives, something about exemption.
There are a few states
and you
that
said
was
they have
mentioning
birthing
that.
centers, and can you speak on that?
Well, the states that Debbie mentioned where, let me do this backwards. There are white states there on that map where those midwives in those states, there's no regulatory statute, and the definitions that are in the Practice of Medicine, the Medical Practice Act or the Nursing Practice Act, or both, identify what those people do is the same thing as what midwives do, but they say it's the practice of medicine. Okay? So if a midwife has no regulatory statute protecting her, and she's caught or she has a bad outcome and is accused of practicing medicine without a license, the only recourse there is for anybody is a criminal prosecution. And while there haven't really actually been all that many prosecutions, considering there's these unlicensed midwives out there and people having babies all the time, midwives in those states are vulnerable to a prosecution like that, and it has happened. In the other states that Debbie mentioned, where those practice of medicine and practice of nursing statutes, in their definitions, they exclude midwifery. So if you're practicing midwifery, you can't be prosecuted under the Practice of Medicine Act. At the same time, there's no regulatory statute in place, and one of the functions of regulatory statutes, one of a number of functions, is that they do offer some protection for midwives, okay? So in those states, a midwife might not be able to be prosecuted under the Practice of Medicine Act, but she might still be prosecuted for gross negligence or manslaughter or whatever the results were. So maybe it's better than the states where you could be prosecuted for felony practice of medicine, but it's not optimal for the midwives or for the mothers. The status of birthing centers varies from state to state. The laws about and requirements for birthing centers are quite different in many states. Florida has a really good statute, maximum of 3 birthing rooms equals a birth center, so no hospital can call their place a birthing center like they do here. Our state has a really challenging statute for the rules and regs for birth centers. Several times I've been involved with people looking into the possibility of starting a birth center in Georgia, and the rules are impossible. You have to have a huge investment in your house, and then your backup doctor can say, sorry, I'm not going to do it, and you can't open a birth center.
I'm speaking of the midwives that we're talking about with the exempt.
Right, and in many of those states, they're working on legislation to get regulation. The ones that have the birth center are licensed in another state. And they actually, because I've been trying to figure out how they did it, and they're using their license from the next state over, and their CPM. I know.
I'm gonna skip along here. I think we've spent enough time on.
They're directed to midwives, but they're certified or licensed.
Okay. So just to sum up, it's kind of like requiring Ford to get General Motors permission to open a showroom when you require a midwife to essentially have permission of a physician in order to have a practice. Midwives are well trained to assess risks and refer medical problems to MDs or obstetricians, and in fact they do that and they have good outcomes. They're good at getting moms that have medical problems to doctor care and not doing them as home births, because that's their training, and they have a lot of motivation to have healthy mothers and babies. Again, all midwives I've ever talked to would like to have a consultation relationship with a physician. And I just wanted to point out that there are other doctor, non-doctor consultations that go on. For example, psychologists cannot prescribe medicine for, say, depression. So you can, in my family, one of us then went to our family practice doctor. Family practice doctor had no formal relationship with the psychologist. He talked with us for a little while. He's not a psychologist, he's not a psychiatrist, but he could write the prescription that was recommended by the psychologist. So what is different about a midwife and a referring and getting help for somebody whose problems are beyond her training to do? It's done all the time. And there's some other examples, but that's probably the best one. But family practice doctors refer to cardiologists, endocrinologists, all kinds of specialists. But they give you the name there. They call the person up. They don't have a written agreement. So it works without requiring an agreement. Another control tactic is to require the mother to see a physician and the physician to sign off and say, yeah, this person's okay for a home birth. In the wrong situation, and you have no control over that, the physician cannot okay anybody for a home birth. If he's got he or she has the ultimate say, they can control whether that midwife has a practice or not. And as a woman and a citizen, I do not feel that it's in the role of the legislature to require me as a healthy person to go to a medical doctor. I might choose to do that. The midwife might recommend that. I can have informed consent over that, and I could refuse. I should be able to refuse to do that. Another non-productive requirement is rigid risk assessment schemes. I'm not a specialist on this. I know Florida has a pretty complex one, and I've heard midwives complain about it. But basically, no point-by-point little risk assessment system really takes the whole woman into consideration and the midwife's experience into consideration. Emergency medication. Some people think, oh, you're saying these midwives should have prescriptive privileges, and I know Georgia was the last state in the country, I believe, to let nurse midwives have prescriptive privileges. Well, we're not really talking about full prescriptive privileges here. We're talking about that part of a statute ought to allow midwives to obtain and administer certain specific drugs or controlled substances for treating emergency situations.
Formulary.
What?
Formulary.
A formulary, right. And a formulary can be in the rules and regs because that might change over time. But to be able to have oxygen and to be able to have Pitocin to administer in the rare cases of hemorrhage after birth, while you're getting the EMTs there, that would be a good thing. That would be good for mothers and babies. And state-mandated medications also.
Prophylaxis is the only thing that's state-mandated.
Oh, okay.
The others are standard.
Sorry. Okay. And another problematic is that it's sort of one size fits all. A list of midwife cannot attend this woman and that woman, this condition and that condition. Those things, you might have some of that in the rules, but there needs to be a provision for a woman who has one of these, even if the legislature says, well, we really don't want midwives running around and doing VBACs all the time, even though the evidence says you should be able to. If a woman has a right to refuse medical treatment, that right is foundational. It's all over the place. It's been upheld rather by the Supreme Court in case after case. So if a woman says, no, I'm not going to the hospital because they're going to cut me open if I go, there should be provision in the statute for the woman to exercise her informed right to refuse and also not be abandoned by her midwife, not require the midwife to abandon her because she's exercising her right to refuse medical treatment. And VBAC in particular is that way, but twins and breeches are also that way because in many places it's an automatic cesarean. And while there are risks involved, it should be the decision of the midwife and the mother to make a decision about what risks they're willing to take, not mandated in a law. It discards the variations among women. For example, a VBAC where the woman had a cesarean and, say, 2 vaginal births after that, and now she's pregnant again, is still a VBAC, and it's very different from a woman who had her first baby with a cesarean 10 months ago and is going to deliver before her scar is a year old. 2 very different situations, but under rules that say no VBACs are treated the same way. Okay, you can read the rest of that one. I'm trying to hurry along because I think I'm taking too much time. So, what do midwives need to practice safely? Legal status, ability to order medical tests, blood tests, etc., ROGAM tests, as needed. Ability to obtain and use emergency medicines. Now, I know in one state, I don't know if this is still the case, but at one time in the entire state, I believe of New Mexico, where the midwives, the licensed midwives, were able to administer these drugs, these substances, but they could not obtain them except through a physician. There was a single retired physician who got the stuff for all the midwives in the state, and they didn't know what they were going to do when he died or stopped doing it. Well, that's no way. If the midwives are able to administer these for emergency purposes, they ought to be able to obtain them.
States that have like a card that lists what they can carry.
Go ahead.
In some of the states, they have a formulary card, the midwives who are licensed. And they take those, they can use those to get those specific medications without a problem instead of trying to look all over for it.
And the respectful interface with the hospital staff that allows continuity of care for the mother, which is a very important value, especially in childbirth, and be able to provide records and information if there's an emergency. And the one thing I wanted to go back to about the limitations on what midwives can do. Clearly there are some medical conditions that you would not advise having an out-of-hospital birth. Mother has a heart condition or kidney dysfunction or any number of other things. And I just want to reiterate that in the huge majority of situations, the mother, if the midwife says, you've got this medical problem, you really need to be in the hospital, I'll work with you to find the best situation you can, that mother's going to go to the hospital. So we're really only talking about leaving, not making a blanket mandate about what can and can't be done, but leaving the door open for the mother and the midwife to make decisions. At the same time, the midwife's training is going to say, I really cannot do this one at home. I'll help you find other care. And it's only the rare mother who will, in that situation, refuse medical care, which she still has a right to do. Okay, so we've gone through most of these issues, and I'm going to go through the last couple very quickly here. I only have a couple more slides. So, for Georgia, who would be the licensing body? And I have a little more information about this on the next slide. We want to consider the cost of licensing versus the number of midwives, because in most states like Georgia, if you have an independent licensing board, the rule is that the licensees have to pay the cost of the board. If you only have 5 or 10 licensees, the cost is prohibitive. We have to look at, in reality, in practical sense, if we want a statute that's going to increase access to midwives for people in Georgia, then midwives have to make a living, and their costs of becoming a midwife and their costs of practicing can't be more than what they're going to earn. So that's one reason why it needs to be done in a way that can get Medicaid reimbursement, since about half the births in Georgia are paid for with Medicaid. If you're going to have, yes? Oh, sorry.
What is Medicaid reimbursement rate?
I'm sorry, I don't have that information.
The doctor knows.
The current Medicaid reimbursement in the state of Georgia is $1,350 for code 6520, which is a normal vaginal birth. Now, Medicaid also will pay for ancillary services such as ultrasounds, non-stress tests. They do not pay for urinalysis that is routinely done on some OB visits. The Medicaid reimbursement in 1988, when I entered practice in this state, was $1,750 and reached a high of $2,100 in about 1994. So the Medicaid reimbursement is dropping precipitously, and that's why you're seeing more hospital-based midwife clinics in this state.
That's $1,350 for Global B?
Global OB care.
You may not want that.
I understand that, but this is an issue that needs to be addressed, because if you don't, even if many midwives sitting in this room say, oh, I don't even want to bother with Medicaid, there are people that want to have their babies with you who can't afford to unless they can pay with Medicaid. So how are we going to address disparities versus making this kind of care available to all the different communities in this state? Okay? So maybe a separate issue, and there's many issues we've been brought up here that are not going to get fixed by one midwifery licensing bill, but maybe another issue that needs to be addressed is reimbursement, the Medicaid reimbursement rates. Bigger thing than I can do. Okay, so we need more midwives. There are no direct entry midwifery educational programs in Georgia right now. So how are new midwives supposed to become new midwives if they got to go out of state or someplace? There's a great model for that with the Miami-Dade Community College program. It's the only direct entry midwifery program in the country associated with a public college, and the only one where students are eligible for federal loans, to get federal loans. And there's a need for public education, that the public health department or whatever other entity of the state government, because we have had, 50 years of indoctrination that midwives are dangerous and dirty and da-da-da-da-da. So how are we all of a sudden supposed to have communities of people understanding that this is a reasonable and safe option for their birth that they can do? So there's got to be a public education component. And I would add, so in the rest of the country, New Hampshire is the only state with an independent midwifery licensing board. Now, I use the word licensing a little bit loosely because a number of states call it certification or documentation or something else, and then in New Hampshire is certified midwife, but it is in fact the same thing as licensing, so I'm just going to say licensing. They are the only state with an independent board in the whole country. All of those other 21 states have some kind of a advisory board that advises an already existing board. In most cases, whatever that state calls their Department of Health, public health. Some states have a Department of professional licensing. I don't think Georgia has that. And 3 states, and one of them is Louisiana, which was an early state to get licensing law. The Midwifery Council advises the state medical board, and I know in Louisiana it took 7 years for that board to come up with rules, and they only did it after the midwives filed a writ of mandamus to get them to do it. So the medical boards are not always the best thing. On the other hand, Virginia passed their law a year ago, and they're under the medical board, and it looks like they wrote their bill very, very carefully, so the medical board has no wiggle room to make life difficult. At least that's what we hope. And the one thing I would add is that one of the things that a licensing system needs, and especially if there's an advisory board like that, is that there's a real mechanism for consumer input on the board and the rules and regulations, not just the professionals, but the women also, and to have some hospital obstetrician's wife be the public member of a board like that does not cut it. Okay. Basically, especially the early laws that were passed in the country, almost in every case, the cost of licensing was subsidized by public health, and because those states realized that this is a public health issue, this care was to be available, and it's not like a lucrative private obstetrical practice. You're not going to make that much money, and some of the rural practices are not going to make much money because they're in low population density areas. So that's probably may not be possible here in Georgia at this time, but maybe it is, that there can be some financial help to get the licensing process and build up the numbers of midwives. Because in most professions that get licensing, there are already lots of them practicing legally in the state without regulation. And then when there's several hundred of them, they go to the legislature and get a licensing bill, and they have no problem. They have plenty of licensees to pay for the cost of licensing and have a very nominal licensing fee. And we have a very strange situation with midwives in that the legal status is pretty vulnerable because there isn't any regulation. So we don't have tons of midwives, advertising in the yellow pages and doing educational programs and marketing their services. So we don't have very many midwives. How do you go from that to a fully self-supporting board overnight? It can't happen. So that needs to be taken into consideration. So basically balancing safety and health benefits with the costs. Some of the costs, education, certification, license fees, etc. Income requires, I think we already looked at this one. I already looked at this one. Oh well. I know time's running out, isn't it? Okay. So basically we need a mechanism to keep midwives who are already practicing. So to have a statute that says the day this statute goes into effect, you have to be a CPM in order to get a license, and you can't practice until you get your CPM. It is not very functional, given that, a quarter of the midwives in Georgia are CPMs? 10 out of 40, something like that. So my suggestion would be that in the bill there be a provision for grandmothering, at least for grandmothering. That's a term that's used to say that people that have been practicing can continue practicing and give them a generous amount of time to get a CPM. And maybe put the amount of time in the rules and just say the statute will make a provision for allowing time for already practicing midwives to get the credential.
What is your best guess about how many midwives? I know you said maybe 10% are CPM, so you have to have some type of idea of how many midwives there are in Georgia. Just a guess.
40 or 50.
We think there's about 40 or 50 midwives practicing in Georgia, and 10 of them are CPMs.
10 are CPMs.
Okay? It's not cheap to get your CPM credential.
How long does it take to get your CPM credential, and how much money? How much does it cost?
Yeah, why don't you answer that?
By me. The CPM, depending on what route of entry they take, is if they come through as an apprentice-trained midwife or didn't go through a formal, like a MEAC program, it's a specific Midwifery Education Accreditation Council, there's $700 for a portfolio evaluation process review, and if they didn't go through one of the other approved routes, it's $700 for the written exam. Mm-hmm. It takes through, if you're coming, the whole certification process, not counting the time they were schooling, is about 4.5 months. Mm-hmm. The schooling and it usually runs between 3 and 5 years.
And the schooling takes place?
It can be community-based, preceptor-student, where the apprentices, the students work with the midwives.
The experienced midwife.
With the licensed midwives, there's CPMs, and it's on-the-job training, basically, hands-on.
Over 3 to 5 years?
It runs between 3 and 5 years.
Because, as Debbie mentioned last week, the CPM is a competency-based credential. So the NARM, in a sense, doesn't care how or where you learned your knowledge and your skills. They just care that you have the knowledge and the skills that you need to start practicing. And that's why it's not attached to a program. The the CNM credential is a program-based, and so the ACNM says if you go, and I may have the names of the organizations wrong, but if you go through one of our approved programs and pass our exam, you can be a CNM. Now, the rationale is that the CNMs did have all the experience and learn everything they needed to in their program. But I personally have talked to some CNMs who really didn't get some really key things. They just never happened to be where that was happening at the right time. And so they kind of slipped through the cracks on some of those skills. I'm not saying that happens to everybody. I just happen to have talked to a couple of different ones over the years that happened with. And that doesn't happen with the CPM credential, because you got to have all those skills and knowledge. You got to be checked off by your preceptor, or gone through a MEEC accredited program where you're essentially checked off on everything, and pass not only a written exam but a hands-on practical exam also, to make sure that you have those essential skills and knowledge.
The nice thing about the apprenticeship program is that the students start attending clinicals, prenatals, births, postpartums, basically from day one. And for that whole time period, they're on the job hands-on. So instead of going into like a didactic program and then working 3 months real quick catching babies and doing prenatals.
Is it possible for us to see the list of the skills that they have to learn in the process?
Certainly.
Is it in our packet?
From last week, yeah.
This one?
Sally, the applications are on online too.
That has the list of requirements.
Okay, so we need to keep the present midwives working and not make that impossible. We need to increase the number of midwives in order to reap the benefits of having more midwifery care in Georgia, like many benefits. And so then we also need educational programs in Georgia. And one could be something on the lines of the Miami-Dade midwifery program. What if we had that in Atlanta? You know, any number of possibilities.
With a couple birth centers for the students.
And with a couple birth centers, that's right. So then we need, oh yeah, sorry.
Are there any other courses, like books or things like that? Is that any other course?
There are several actually MEEC accredited programs that are at a distance learning. So you would do most of your book learning at home, and then I think you'd have, the programs vary somewhat, but you have to spend a few short amounts of time at the school home base, and you have to have a preceptor in your locality, basically. So
For the books.
and you would have to get some books too. Yeah, that's part of part of the cost of education would be.
It's not included in the 2 courses that you just gave.
You'd have to get your own books. Yeah, and they can be expensive, but I'm hoping that we can think creatively about how to address some of those challenges and obstacles so that it doesn't keep some people out. So we need some public education materials to overcome present beliefs, and we need financial aid for midwifery students that help address needs for community-based midwifery that's culturally appropriate and that's from all the communities in Georgia, not just African American and white, but Hispanic and Oriental and Islamic. So, for a quick summary, for most states that license direct entry midwives, no doctor backup is required and no doctor sign-off is required. And as Debbie mentioned before, most states do require that the midwife have a transport plan for each client, and the client is informed of that plan. And I believe that there's no evidence that having doctor backup or sign-off improves outcomes for mothers of babies, but we do know that it decreases access to midwifery care. And in states that have been most recently licensed, most of them, I'm a little fuzzy on that, Debbie can correct me, but generally things are moving towards licensed midwives having access to this limited list of emergency substances, and most do not overly limit who licensed midwives can attend. That could be done to a reasonable extent in rules and regs, but there should not be a laundry list in the bill, because healthcare changes, and you don't want to have to redo your bill. And a beautiful example of that is the 1955 Lay Midwifery Act that's still on the books. In the statute says no vaginal exams. Well, that you couldn't practice that way today. But in 1955, most people lived on farms. You couldn't go down to the drugstore and buy sterile rubber gloves. It probably made sense. But it didn't need to be in the statute. That kind of thing should go in the rules and regs so that it can be changed with the times. Okay, summarizing, in the majority of states there's an advisory council of some name to the state health board, and it's the advisory council that comes up with the rules and regs and essentially does most of the work of what a licensing board would do, but the health department board or similar is the actual responsible board. And in a few states, licensing is still subsidized by the state government. And finally, licensing direct entry midwives is a public health issue. Women are already giving birth with unlicensed midwives. There's no accountability. Women and babies should have access to evidence-based and health-promoting midwives model of care. And emergency preparedness, as I mentioned last week, when you have the flu epidemic, possibility, pandemic, etc., public health interest would be to have people in every community who are well-trained to help women have babies and never go inside a hospital and be exposed to the infection or other problem. And it's also a human rights issue to respect women's choices, needs, and rights, and to assure access to appropriate care and not overdone care.
I have one more question.
Yes.
You said women are already giving birth with unlicensed midwives. About how many births at home are taking place in Georgia?
Well, Georgia government has decided not to make records of that. There's no way to differentiate in Georgia at this time between planned births attended with a midwife and precipitous, accidental, unplanned, etc. births. They're all at a hospital, and they may be, if it's on the way to the hospital, it might be signed off by a doctor or hospital staff person, and it'd be confusing whether it was in or out of the hospital, but there are not records being kept on that in Georgia. Haven't been for a long time.
How many out-of-hospital births were there last year? Do we know?
I don't have that number off the top of my head.
Can you get that, Sarah?
In general, in the country, even in states where direct entry midwives are unlicensed or not legal, it's not over 1% of births.
Okay.
But how many, it might be half of those are planned with a midwife, or 3/4 of them are, nobody knows where those records are not kept. That's another reason for licensing or regulating midwives, because then you can attach that information on birth certificates.
If they file a birth certificate, usually it's on the form that's
But it's not really an accurate way of saying it was a planned, attended birth.
You could probably make a guess that it's somewhere, each midwife does 20 to 40 births a year, times the number of midwives that there are.
So, you want a question? Oh, fix the end of, yeah. Thank you very much, and I'm sorry it went over time. I was trying not to.
Do you want to send her to the back?
No, I actually have time. Thank you so much. It was very informative. And I am now going to hand the gavel, so to speak, over to my co-chair, our co-chair of the committee, Representative Amy Mabel Thomas. And we are just so happy that she's joined us. And I know she had a very important commitment that she could not get out of, which is why she was running late. But I'm going to let Representative Thomas speak and then finish off with the program. And I apologize for having to leave early. Thanks.
Well, before you go, we'd like to ask that we give her a big hand for the work that she's doing. I would like to just thank all the members of the committee and say Godspeed to you as well as the audience. I did enjoy the presentation that was presented. I basically just wanted to say that my understanding of the information that was given out at the first meeting did have emphasis on infant mortality and how we can have midwives who play such a very important role in maternal care to be able to be have a positive impact on that particular situation as well. I would like to say that there is a member of the committee that does have a document that probably needs to be brought up, but what we like to do before we do that is to bring on, since we are looking at other states and what they're doing, we'd like to bring on Miss Claudia Kahn, and she's a Tennessee licensed midwife, and then Miss Debbie Church, and you're also a Tennessee licensed, is that right?
They're going to speak together.
They're going to speak together, so it's time we'd like to ask them to come on. Let's receive them.
Debbie, ma'am.
Other Debbie. Debbie was she? Debbie 3. Debbie Snyder. Or do you want to just do it? No, you need to talk. Yeah.
I'm going to go first. That's okay.
Okay.
Thank you.
So good to be here. Debbie Church.
Church, okay.
Yes, ma'am.
All right. A lot of Debbie. It's only right that Debbie's end up being midwife.
Well, I know.
No, we were all born in the 50s.
Debbie Reynolds.
My name is Debbie Church, and I'm actually from Athens, Tennessee. There is one. And it's a little hole in the wall, a little bitty farming town that grew. And we happened to land there, and I had 5 home births, unassisted, with nobody there, because I couldn't find one. I couldn't find a midwife. And so hence, I'm here now. And that was my impetus to be able to seek out and try to find a way to be able to serve women in a way that was needed. So, and here I am today here. I am presently a certified professional midwife that's licensed in the state of Tennessee. I have about 25 years of experience under my belt, 700 babies or so, which in the scope of things is probably not very many for you. But I'm relatively busy. I do about 40 to 60 babies a year, and that puts me doing a baby a week, just about. So I don't have vacation time. I have other hats too. I happen to be on the board of or on the council in Tennessee for certified professional midwives. And right now, I want to try to help Georgia midwives get a licensure here. So, a certified professional midwife on the national scale is with the North American Registry of Midwives and has sat under rigorous testing, of which they've spoken of tonight. It's scrupulous and demanding, this testing that they do. It's very difficult, sitting for the exam. The state legislature in 2000 created a law for the Tennessee midwives, and it's called the Council of Certified Professional Midwifery of Tennessee. It's responsible for safeguarding the health, safety, and welfare of Tennesseans by requiring those who practice as a midwife to be qualified. Midwives are required to pass the CPM exam and qualification process and then apply for the state certification. The council, working with the Board of Osteopathic Medicine, we are council under that board. We don't have enough money to really have our own board, per se. It's just very expensive to keep one, and so we chose to be a council under that board. We're not, and somehow we're under the Board of Health, and I'm not sure about all those details, but anyway, they interpret the laws and the rules and the regulations to determine the appropriate standards of practice to ensure the highest degree of professional conduct. The council is authorized to issue licenses to qualified candidates who have completed appropriate education and successfully completed required examinations. The council, along with the board, determines the appropriate standard of care. They do investigations where people have gone against the laws and rules, and discipline licensees
who are found guilty of such violations. Many of today's consumers view midwifery care as a desirable alternative to the medical model, which tends to view birth as a pathological process fraught with danger. Midwifery philosophy recognizes birth as a normal process with far-reaching effects for the family. A positive birth experience is a desirable foundation for the start of a strong, healthy family life for all Georgians. In most countries, I'm sorry my speech is not memorized, but in most countries, including but not limited to Sweden, which has the lowest infant mortality rate in the world, Iceland, Norway, and Finland, midwifery is more than a well-established and respected profession. It is the standard of care. When midwives care for the majority of low-risk women, some of the world's best perinatal outcomes are recorded. And I have statistics, probably some of the same ones that were given to you in the last meeting, from what I understand, that from the CIA website or whatever, but they're in the packet that I gave y'all. The United States, this is a quote from CNN, May 10th, 2006. The United States has more neonatologists, more intensive care beds per person than Australia, Canada, and the United Kingdom, but its newborn rate is higher than any of those countries, said the annual State of the World's Mother Report. The newborn rate of death is higher than those other countries. And the people in Georgia, the women here, are going to have their babies by themselves. And my whole point in all that is that women need these midwives. They need this care that they're giving them. They need to be able to have somebody who can refer them to a physician if they so need it. And that's what I'm trained to do. I'm trained to stop a hemorrhage, get a baby breathing, and I'm also trained to refer over to somebody else at the time of need, which is where, if in Georgia, if they can allow this licensure to happen, it will help the Georgians be able to have better care. Plus the fact that they were talking about, up here on the screen, they were talking about maybe even allowing somehow the Medicare to help pay for some of these midwives to be able to have the state be able to help pay for some of these births that happen. Well, the socioeconomical impact for the state of Georgia, if that could possibly happen, would help reduce the amount of money that the state of Georgia has to pay for each baby to be born. There is no facility fee for, on the other side of the coin, they were saying that these places weren't getting the money. Well, there would be no facility fee for the state of Georgia. There would be no perinatologist if they didn't need one. There would be no resuscitation group at every single birth, except for maybe a limited amount of midwives and maybe an assistant. So my point is that the state of Georgia really needs a legislation implemented to be able to help the midwives be legal, perhaps maybe even get some of this money so that they can propagate themselves and encourage others to have safer home births. Some of the things that have helped the Tennessee midwives is it has helped to be able to move into a smoother recognition of transports and helping to be able to have access to these labs that they didn't have access to before, and also getting reimbursed by public insurance like Blue Cross Blue Shield, Provident, and a few of those places. We also do birth certificates for every baby, and we do newborn screening, which the state and I communicate back and forth on a regular basis about all of those issues. And it makes less work for the people at the health department to be able to have these things available to the midwives and the mothers. I also realize that the midwives in Georgia are not afraid of the accountability factor for the state to be able to watch over these midwives and make them accountable to the state of Tennessee, to the state of Georgia. Georgia midwives are not afraid of being held accountable for the actions of themselves or their colleagues. They want credibility, accountability for Georgia midwives. This concept is not a new one, nor is it something that the midwives in Georgia are adverse to. The midwives here are hoping that all Georgians can enjoy the wonderful choice of freedom and independence of a home birth. Being on the board, you guys are asking a lot of the questions about the board. If you have any questions about how the board works, I'd be glad to answer any of those. The Council of Midwifery.
How many members is laid up on them? Are they professionals and lay people weeks together? Or what's the
In the council?
Yes.
Well, when we first started out, we had 4 or 5 midwives, CPMs, and then we had a nurse midwife. But now, and we did some administrative cleanup stuff with the law. We took the law back, and now we have 3 CPMs, and we have 1 nurse midwife, and a physician, and a consumer. And that has made it much easier for us to get together, much easier for us to do our administrative work.
There's no lay midwife.
Yes. Well, if you want to call me a lay midwife, that's...
She means non-certified.
Right. No. The whole point is to try to help make the midwives accountable to one another and to the state. And so we want all the lay midwives to get on board and do the certification and get the licensure. We do carry drugs. That was one of the things that was up there, which I think is very important. We carry oxygen, and I personally have a collaborating physician where I collaborate with. I like that, like Debbie or Susan was saying. I want that. I want to be able to have a relationship with a physician that I can call up and say, hey, this is what's happening, what should I do? And, or what would you recommend? And then I can give my mom her recommendations, and then they go from there as far as, but mostly it's all what they want to do, what my clients really want to do.
Is there, based upon what you've already heard in terms of other persons who presented, how is the process of getting licensure in Tennessee different from what maybe some other states, or specifically what we're trying to push forward in Georgia? Do you see any distinctions or any particular things that you think that y'all did that was creative that might be helpful for us?
Well, I think Susan was talking about some of the things that I thought, that's a really good thing that I hope Georgia implements, is the fact that, number one, the things that are put into your law, you could have your law, and then you could have your standards of practice, which could be the standards of practice, which would be much easier to change than the actual law. Mm-hmm. And keeping your council small would be my recommendation. Keeping the council small, because you get too many people in there, and it's very expensive for the state.
It's good to have a lady. It's good to have conversation.
Well, we have a consumer.
Oh, that's the lady midwife?
Can be.
But she could be. She could be. We really wanted to protect also the midwives in the state of Tennessee. Really wanted to protect the religious midwives, the ones specifically who were with the Amish and the Mennonite. And we did not want to hinder their ability to be able to still deliver babies inside their community. And in Florida, it is a felony, and you will go to prison. It's a criminal felony to deliver a baby at home. Unless you're licensed. I'm sorry. I meant that. Thank you. But it's not a felony in Tennessee to be a community midwife. So,
How does your law address that?
Is it still exempt from the Medical Practice Act as it was before?
Tennessee was one of those states that was exempt from the Medical Practice Act to start with, so they were practicing openly as it was. But then they went on, decided to go for licensure. So it's not changed what it was before, except for, is that right?
yeah. Except for now I have to pay money to get a license.
Yeah, you do.
So
Is risk assessment part of, is it in statute or the policy?
it's part of our practice guidelines.
Practice guidelines.
And all that is available online. And after I got here and heard Susan, I was like, man, I wish I brought my law. I wish I'd made copies. But evidently, I think y'all have all that here. So, And Susan also mentioned, and this is probably very important to y'all, but the fact of our startup costs for our council. We actually have a pool of money. In Tennessee, I don't know how it happens in Georgia. I'm just going to tell you how it happens in Tennessee. But in Tennessee, how it works is all the licensure money goes into this big pool for osteopaths, MDs, massage therapists. So it all goes into this one big pool. And then whoever needs it, they use the money for that. Well, our startup costs were well over $20,000. But that just happens. We realized that we weren't going to be able to keep ourselves covered and in the black. And so when our law came up for sunset, before it came up for sunset, we decided to up our fees. And currently we are paying $1,000 every 2 years. But it is well worth that for me. It's well worth that cost. So at first it was $500, but it went up to $1,000 every 2 years.
How many licensed midwives are there in Tennessee now?
36. I couldn't remember if it was 34, 36, or 39.
Will your licensing fee go down?
Okay, as we project that in the next 2 years we'll be running in the black. And so our fees will, at that time, go back down to something that's a little bit more reasonable. But the startup costs were just overwhelming, and we wanted to keep our law, and when our law came up for sunset, the financial people wanted to say, okay, well, how are you guys going to offset the costs of all this? So we all chose to do that. The council chose to raise the fees. Some of us were under duress. Me. But anyway.
I saw one more hand, and then I want to ask Ms. Claudia Kahn to present. And if we're only because of the clock back there says it's like something to 11, but actually it's something to 12. Correct. And so I want people to be able to have time for dialogue, and I do have a couple of people who signed in, so if you could just do it.
Thank you, Debbie.
Thank you.
We do appreciate that. Let's get in.
There's this button.
I'm Claudia Kahn, and I've been asked to speak on the advantages of direct entry midwifery licensure from my own perspective of having practiced both as a licensed and an unlicensed midwife. I know that in the interest of time, I know that there are attendees who want to speak, so I have a PowerPoint presentation. I'm going to pretty much just stick with the program, and if there are any questions, please let me know, but I will try not to diverge. To tell you a little bit about my background, my first child was a planned home birth in North Carolina in 1980. I began my path of midwifery training by pursuing an education to become a nurse midwife. I moved to North Georgia in 1982 specifically to attend Emory University, having recently completed my undergraduate training at Duke University. As a student at Emory, I quickly learned more of the politics of home birth as they relate to nurse midwifery. It soon became clear to me that to develop a home birth practice as a nurse midwife would be difficult to accomplish anywhere in the country, and that it would be virtually impossible to do so in the state of Georgia. I therefore chose the only viable option available to me and continued a course of apprenticeship-based training as a direct entry midwife. In the early 90s, I pursued national certification as a CPM as that process came into being. In the meantime, I had 2 more children at home here in Georgia, both of whom were born into the capable hands of Georgia direct entry midwives. At this point, I have been involved in midwifery practice for about 27 years, the last 25 of which have been spent in Georgia. I have attended more than 700 home births for families through the years as a primary midwife, providing a full program of prenatal, antepartum, and postpartum care. Like so many other Georgia midwives, I have applied for and been refused certification under Georgia law. In the last few years, as Tennessee has put midwifery legislation in place, and as I have experienced increasing political challenges to practicing midwifery in the state of Georgia, I have pursued Tennessee licensure, which is based on the CPM credential, and I have opened an office in Chattanooga. 3 other Georgia midwives have taken the same step of attaining their Tennessee midwifery license in the past few years for reasons related to political advantages of state licensure. They are Debbie Pulley, Debbie Snyder, and Carolyn Drake, who is not here with us today. And so, again, I offer my thoughts on the advantages of state licensure for direct entry midwives from someone who has practiced on both sides of the fence. The demand for home birth exists regardless of politics. In the state of Tennessee, the CPM process is the basis for legislation and state licensure. There are 36 CPM TNs, which is the term for a licensed Tennessee midwife, practicing in Tennessee. Many families choose to cross state lines in order to give birth legally at an out-of-hospital birth center in Tennessee. In Georgia, neither the CPM or any other direct entry process is recognized. CNMs do not attend home birth in Georgia. This leaves Georgia families with no legal access to trained home birth attendants. Currently, there are approximately 40 direct entry midwives across the state of Georgia. About 9 Georgia midwives are CPMs, but politics curtail their practice to varying degrees. Throughout the years, I have watched midwives stop practicing or leave Georgia in order to practice in a state that provides licensure. I have observed apprentices shy away from training and practice specifically because of Georgia politics, and have generally seen very little change in the number of CPMs who offer home birth services in Georgia as the years go by. The lack of licensure and related disincentives for midwifery practice may lead to more unattended home births and births with untrained attendants. More Georgia families will be forced to travel out of state for legal out-of-hospital birth if Georgia politics do not improve. And again, at this point, there are 3 states that are immediately adjacent to Georgia that have licensure that families have been and are traveling into in order to have legal out-of-hospital births.
Excuse me. What do you call unattended births?
I think an unattended birth is a birth in
Untrained attendants. You know, with births.
I would say, just in general terms, an unattended home birth is a birth in which a family chooses to birth at home and there might be other friends or family members present.
That's untrained. That's what you're speaking
That
of.
would certainly be
And
untrained.
they're talking about just lay midwives or, direct entry, ones that don't have license per se.
Well, I know that that's a question that has been raised today as far as the status. And I know that Debbie Church spoke to that as far as Tennessee, the fact that those midwives continue to practice outside of, as a practice of medicine, outside of the practice of as the practice of midwifery and not the practice of medicine, and are not culpable for any liability or any criminal liability in their state. Licensed midwives are more effectively able to serve the needs of clients in many ways, such as midwife accessibility. In Tennessee, CPMTNs can maintain offices and develop websites, classes, and other educational resources for improved client care. In Georgia, midwives often practice underground. Families seeking birth alternatives may have difficulty finding a midwife or may be unaware of the option of home birth. Birth certificates and newborn screening. In Tennessee, CPMTNs can legally file birth certificates and do newborn screening. In Georgia, midwives cannot provide these important services. Lab work. In Tennessee, CPMTNs can order routine lab work done for clients. In Georgia, unlicensed midwives have more difficulty meeting these client needs. Medications. Certain prescription medications are basic to safe midwifery practice. In Tennessee, CPMTNs can legally carry oxygen, IV setups, Pitocin and Methergin for the treatment of hemorrhage, vitamin K, erythromycin ointment for eye prophylaxis, and local anesthetics for suturing. In Georgia, these drugs are not available for legal use by Georgia midwives. Licensure provides for increased home birth affordability by enhancing the option of insurance coverage. Several states now also have Medicaid reimbursement for home birth. In Tennessee, midwives report a significant proportion of clients have some level of insurance coverage for home birth related care. In Georgia, most home birth families pay completely out of pocket, as most insurance will not cover home birth related care.
Does Medicaid pay in Tennessee?
Not yet. Licensure enhances an appropriate and integrated support system for home birth. Most home birth studies show a 10 to 15% rate of medical referral or transport from planned home birth to a hospital-based care. A responsible home birth plan includes a Plan B for medical support, referral, and transport. In Tennessee, licensure allows CPMTNs to provide care and to seek medical support where appropriate without the fear of criminal liability. Also, medical providers are more inclined to support families working with these state-licensed midwives. In Georgia, lack of licensure can create challenges for midwives and families seeking appropriate medical support for planned home birth. Most medical caregivers in Georgia will refuse care to women prenatally if they are known to be planning a home birth. Most of my clients travel an average of 2 hours one way during their pregnancy to see a physician who is respectful of their home birth plans. When the need for medical care arises in labor, the lack of medical support often leads home birthers to transport into the hospital on a, quote, walk-in basis without the benefit of an established medical relationship. Lack of licensure in Georgia makes transport difficult for midwives due to fear of criminal liability. Making a decision to shift from home to hospital care is often made difficult by perceived hostilities which may be faced by home birthers and their midwives who go to the hospital. It is important for midwives to accompany families during hospital transport, to provide valuable information about the situation to medical caregivers, and to provide continued support and guidance to the laboring woman and her family. Georgia midwives may feel compelled to drop off transporting families at the hospital or to accompany them to the hospital in the guise of friends. This fear of criminal liability in Georgia is very real, and I cite my own personal recent experience. In 2003, I made a very routine transport into a Georgia hospital for the medical term would be failure to progress, basically a mom who was having a very long labor and not making appropriate progress through the course of that labor. I transported her into a hospital where I had established medical backup care and where she had been had an established medical backup relationship and had been receiving dual care with the physician group. There was never any question of my management on anyone's part, the staff, the physician, the family. The family was very satisfied with their care. In the aftermath of this, the outcome was very positive. The mother got the medical care that she needed. She needed, at that point, an epidural. She got a Pitocin drip to augment her labor, which had become dysfunctional. She labored for probably another 8 to 10 hours in the hospital and ultimately gave birth by cesarean section for her dysfunctional labor pattern and continued failure to progress. In the aftermath of this experience, needless to say, I accompanied this family into the hospital. I identified myself as the midwife, and I stayed with the family through the course of their care, which is appropriate and which is what Georgia Midwives would certainly be their preference for ongoing care and support for the families. A couple of months later, about a month later, I received a call from the Georgia Medical Board and was informed that I was being investigated for practicing medicine without a license as a result of this experience. One of the nurse administrators on the floor of the hospital had apparently simply personal issues of her own, personal opinions about home birth, and had taken it upon herself to turn me in to the medical board. And an investigation followed. Eventually, the charges were dropped by the medical board, since there was no case. That ends my presentation. If you have any questions for Debbie or I.
Any questions? Thank you very much. Okay, what I would like to do now is to, probably I need some help, maybe Sally, but we have two documents that's at the end of the end of the table. We'd like you to take a copy of the document. One document is just a flyer that we put out for a policy briefing that we did last year. I think it was December 6th at the state capitol. And the other one is a document that committee member Linda Nasra Anora is going to present. So basically, just one is just a document that did risk. There's a document that we have given out at another time, but we think it is a good document, has some information related to the issue of infant mortality and home births. Now, so you can go ahead and start just because of the time. Go ahead, okay. The document that was it has draft at the top of it, and the other, as I said, is a flyer that we had at another time for a meeting, policy briefing at the Capitol.
I was looking at that going, cool, party.
Yes, greetings. From the first document from when we had the policy briefing, because you have a concern with the infant mortality, and we connected the midwifery resolution and gave it to a purpose as well, and helping to reduce the infant mortality rates. So in this here, when it has facts that are related to infant mortality in Georgia, that comes from the Department of Human Resources, and it just lists those facts here. The next one is just a draft document, and it's an hypothesis where we believe that when midwives are integrated into maternal care, there will be a respective reduction in the high rates of infant mortality in Georgia's rural and urban areas. And the working definition of infant mortality is is defined as X number of deaths per 1,000 births before a child's first birthday. So there's suggested research in the counties where infant mortality is high, and it's to identify how many midwives live in the area or the surrounding counties, and to identify how many doulas live in the areas or the surrounding counties, and identifying how many OBGYN doctors live in the area or the surrounding counties in the rural and urban, and identify how many freestanding clinics are servicing new birth families in rural counties, and identifying the radius of hospitals in rural counties, and identifying the radius of care in the surrounding counties to the hospitals, and identifying hospitals by name and county, identifying the cost of premature births per month, and identifying the cost of C-section procedure, and identifying how many C-section procedures per county or per hospital, and identify how many birth centers in Georgia by name and county, and identify how many OBGYN doctors are in the rural counties of Georgia and what their radius are to the hospitals. Identify how many doula services are in Georgia's rural and urban counties. Identify areas and how many, or identify the areas and then how many are in each area, and identify the radius of services covered for each county, and identify how many clinics providing prenatal care are in Georgia rural counties in the radius of hospitals, and identify the location of clinics. Now this next one, what are the minimum qualifications for midwife, that was answered kind of today. And suggested speakers, we have Miss Smalley, who we'll get in touch with, who's a granny midwife from Camilla, Georgia, and Commissioner B.J. Walker, who's the State of Georgia Department of Human Resources, and Ronald Matthews, who's the chairman of OBGYN at Morehouse School of Medicine, and the Georgia Hospital Association, and Dr. Stuart Brown, who I understand will be coming anyway. And also, Stephanie mentioned about getting someone from Medicaid to be a speaker as well, so that we'll know more about the Medicaid. And these here are listed more so because there are for the facts that relate to infant mortality, so the suggested research and finding that information would help, in looking at, what that is.
Is this a draft for a future event?
My understanding is what it is that we are fortunate enough today to have Miss Pat White in the audience. And Pat, would you just come up for half a second for me and introduce yourself? There are statistics on this particular information that we believe that through her office or another office would be able to compile for us, so it would be a part of when we begin to look at the recommendation how we go forth with legislation. If you will just state your name for the body. We are thinking that this information could be a part of the process, and we'd like to see how this infant mortality and midwives into maternal care as it relates to infant mortality. We want to keep, even in the midst of the issue of certification, we also think we have an opportunity to look at this high infant mortality rate that's really in the United States, because we're second worst, they say, but we also want to do something about what's going on in Georgia, which I've seen documents that say we're the 12th highest. So I think that this would be an opportunity to integrate both. So just, if you will, just introduce yourself and see in which your office you think might be the office that could help us get some of this information.
I'm Patricia White, and I'm with the Department of Human Resources, Division of Public Health. And I think the data that...
Yes. I think that the information that you want, you can request from the Division of Public Health, because we have the repository for all of this type of information for Georgia. If you want infant mortality rates, prematurity rates, etc., that's where you need to request it. So I think you can. There's a Division of Public Health.
Okay. Okay. And so what we'd like to ask is Ms. Fox, who's working with us, to sort of look at the list of items on this draft document and see can we get that compiled, and then maybe at another setting will bring it forth, but we do know these are the type of things. And also one thing I like to add is just there's a list that I was given, matter of fact I gave out during the session, which had all the infant mortality rates in different counties. We were not able to get that document this morning before I left. And so we like that document because it has been compiled before. Susan.
Yeah, two things. One is when you look at the rates by county, some of the populations are really small and it makes the statistics really screwy. So it might be worthwhile getting several years of that data to look at the trend. If you have one baby born and it dies, and the 50% of babies that were born in the county, it looks really huge. And the last week when we were here, I mentioned there had been a notice in our newspaper out in Athens that the Mini G. Boswell Hospital that almost closed a couple years ago and it was taken over and revitalized, but the obstetrician that works there is leaving or retiring or something, and they're going to end OB service. They have ended OB service at the Mini Boswell Hospital. Women, that was almost 100% Medicaid birth, and those women will have to get to Augusta, Elderton, Athens, or Macon for prenatal care as well as childbearing. And to me, this is a really good example where midwives, whether they're nurse midwives or licensed midwives directly from at least prenatal care in the community, and at least have midwives here that could assess whether it's needed to be in a hospital or to be out of hospital. It's economics that goes out. It's not, the hospital was struggling with that department, it's not worth it. The reimbursement rates make sense, but it's economics making the care not available for the family.
All right. Lance, would you like to say anything else?
That's it.
Okay. All right. Well, at this point, what I like to do is go ahead and bring those people who have signed up to speak. I have 3 names. I have, and you can take it in this order. I have Brenda Parrish, Amanda Larkin, and you will have to help me on this pronunciation. Maya. Say loud. Yes. So those are the 3 names I have. If you will come up in that order. Who's the last person that you say we should invite?
Medicaid.
Okay.
Stephanie says she's going to do that.
I am Brenda Parrish.
How you doing?
I'm fine. I just wanted to speak just a minute from my heart, and I know we only have about 2 minutes, so I will make it very
I'll give you 3.
I can talk slower then. I am a direct entry midwife with 12 years of experience as a primary caregiver, assisting women in South Georgia. At one point, I had decided to become a nurse midwife, and so I attended college and my first year of nursing school before realizing that doing hospital births was not my desire. Most nurse midwives may start out with ideas of practicing a midwifery model of care, but they frequently end up being pressured to use the same protocols as the physicians that cover them. I very much wanted to offer the families I knew something different, a choice. I am now in a 3-year midwifery school preparing to take the norm and to become a CPM. I know many experienced midwives, however, who are not CPMs, and they may never be. They are conscientious, they are educated, they are informed, they're skilled, and they're very passionate about what they do. I myself have attended as many hands-on skills workshops as I can to better my skills and to discover what the latest research is and etc. I would have chosen to do that even if I were not working towards certification as a CPM. I would have done it just so I could better serve the families that choose to birth at home, away from situations that frequently demoralize them and doubt their ability to make informed decisions or birth as their bodies dictate. There is a saying that most of us midwives are familiar with, Dr. Schilling, I apologize in advance. It says, "The midwife considers the miracle of birth as normal and leaves it alone unless there is trouble. The obstetrician sees birth as trouble, and if he leaves it alone, it's a miracle." Herein is the difference in approach between midwifery and obstetrics. We see birth as a natural, normal event which usually proceeds beautifully if left alone. We educate ourselves only for the minority of births which need some assistance. Midwives usually refer to their mothers as clients instead of patients because we don't consider them to be ill. They're just expecting a child. We usually spend huge amounts of time with our clients getting to know their history, their disappointments with previous births, their stresses in life, their nutritional status, their conflicts with their spouses or their partners, their preferences about how and where they desire to give birth, their unique style of laboring or dealing with pain, abuse issues that may be part of their history, their joys, their aches, their pains, in short, their lives. We invest ourselves in each person we assist in birth and give them a big chunk of ourselves. We practice a lot of prevention in order to avoid complications, and we spend time educating our patients in the importance of compliance. Is it any wonder that women who have had a home birth with a midwife want that choice to remain an option and a completely legal one? You've already heard about the very sad state of our country's infant mortality rate. We need to look at the countries that have the best rates. What are they doing differently that is turning the tide in the battle for infants' lives? Barbara Harper states in her book, Gentle Birth Choices, that Japan has had a consistently high ranking among all the countries since 1970s. In 1996, perinatal mortality in Japan reached a historic all-time low, 3.8 deaths per 1,000 live births. What is the difference? In most of the industrialized countries in the world, midwives attend more than 70% of all births, with many of them taking place in homes or birth centers. Japan has seen a resurgence of the midwife-run small community birth center in the past decade, and as we have seen, their infant mortality rate is relatively low. For the U.S. midwife-attended births, the mortality rate drops to 2.1 deaths per 1,000 live births, as compared to the overall U.S. figures of 6.3 deaths per 1,000 live births. This data makes a very strong case for home births attended by midwives. She also quotes Dr. Michael Odette, who authored a 1991 report for the World Health Organization, in which he stated, "The priority must be to challenge the universal propaganda that home birth is dangerous. The best means by which to challenge the current beliefs are the statistics from the Netherlands, where midwifery and home birth are prevalent." I challenge all of you to read this book by Hensie Goer. It's called The Thinking Woman's Guide to a Better Birth. And in this book, she has a very honest evaluation of every intervention that a woman faces when she experiences a hospital birth. She explains every intervention, and she honestly reports on the situation in which those interventions are very needful and very helpful and very life-saving. But she also reveals the research which points to the fact that most of those interventions are overused and at times can even be detrimental. She also, and they also lead to a cascading effect of requiring other interventions and frequently lead to a cesarean section. Many people consider the system of obstetrics to be broken, and we really don't know how to fix it. But we can offer the women of this state a legal, safe alternative if they desire it. If we expect to improve our maternal and infant mortality and morbidity statistics in Georgia, we must legalize midwifery with home birth and birth center midwives. Thank you.
One thing I did notice, the next person is Amanda Larkin. I do really appreciate Ms. Paris. Now, what I did notice on the sign-in sheet, there's another sheet. I need some addresses of some of the speakers, so if you would, maybe another sheet of paper that Ms. Sally could be put out so I can get the address and phone numbers and emails, because this just has the name, and we would like to be able to get back in touch with some of the individuals.
Hi. I wrote down what I'm going to say because I'm going to get nervous. So, my husband and I feel so strongly about home birth that we chose.
You're Miss Amanda.
Yes.
Okay.
Yes, I'm Amanda Larkin. We chose to forego free hospital birth in favor of it. Free because my health insurance would have covered all the expenses for a hospital birth. In fact, I think a common misconception about home birth is that people without health insurance choose it for financial reasons. This may be the case sometimes, but I think a lot of women that have good health insurance, like me,
are also choosing to have home births for reasons that outweigh the financial costs. Having just had my first baby, Riley, at home in October, I can tell you that it was the most empowering and intense experience of our lives. I tell people that we made Riley on our bed and he was born on our bed. I'm so grateful to have found midwives that are willing to give women a choice in where they birth. My experience with our midwives far exceeds that of any OBGYN I've ever seen. They are so thorough, and there's no rush to get you out of the office because they have other patients waiting. They really take the time to get to know you. I appreciated having developed that relationship before sharing one of the most intimate experiences in my life with them. Ultimately, this is all about choice. This is not to say that every woman should have a home birth, but every woman should have the ability to make that choice without worrying about any restrictions placed on midwives from practicing in Georgia. I hope you will remove these restrictions and allow these amazing midwives to help all women who have made that choice. And one other thing, when they were talking about birth certificates, that was a big hindrance for us too, because we had to go down and apply for it, and my family's in England, so now we have to wait to get a passport, and they're all waiting to meet him. So it just, it's a lot of hassle to have to go through after having just given birth, to have to go down and apply for a birth certificate when I should have just been able to get my midwife to do it for us or have her help us get it quickly. That's it. Thank you very much.
Hi, I'm Maya Sonobiu. I'm sorry my name is so strange, but Maya, because I'm Japanese, and I was glad that somebody mentioned about Japanese birth. Yes, I'm from Japan, and I'm married to a guy who was born in Brooklyn, Italian. Everybody say first is toasty and have those accents. But anyway, so now I'm Maya Sonobiu, and I had a baby with and I went to a prenatal care of Claudia Kohn and David Schneider, and I had a baby. He's sleeping now over there in August 12th at home. I would like to share you, I know it's 2 minutes, and when I was writing all of the story, I got emotional, choked up on Friday. So I just decided to just talk about why I chose a home birth. Since I was born in Japan, I always think the birth was something to do with the baby, not just the mother, pushing the baby out, and it's always a very natural approach. But here, learning about C-section rate being so high was making me very uncomfortable. And I was looking at the web the other day, and then I quote this from USA Today, November 22nd of this year. The birth rate among U.S. women and girls aged 15 to 19 declined to record low in 2005. Well, that's great. But the cesarean section increased to a record high of 30.2% of all births, according to data from preliminary report released on Tuesday by CDC National Center for Health Statistics, USA Today reports. And this was just making me very uncomfortable because the doctor will say, well, don't take alcohol, don't drink, don't take alcohol, tobaccos, and then, if you want to take headache medicine, well, you have to consult a doctor first. And then when it comes to labor, they will say, okay, we'll do C-sections, we'll do Pitocin. All of a sudden, all those medicines, things are thrown away to the window. I was just wondering, why all of a sudden at the end. So I wanted to give this baby the natural birth as I can do, because as maybe it's my cultural background, but I believe also this giving a birth to a baby is a natural thing to do. In fact, I read somewhere, I'm sorry, I forgot where I got this quote, but then in 1970, even in the United States, only 5% of the women had a C-section. So we improved that technology, but we can't change our body, but then why we have to get so much C-sections? And also, my reason that I wanted to have this baby safely was because how much I love my husband. And I was so elated when I learned that I was pregnant, and I was so happy, and I wanted to have the baby the best way. I wanted to give the gift to my baby Kai, the safe journey to the world on his birthday, rather than the doctor decide, okay, let's do a C-section. It's like root canals, schedule root canal, do schedule C-sections, whatever. I'm sorry, I'm rude. And help like a safe start without medications. And this is a home birth, and also a great start on the breastfeeding. My journey, also I wanted to have a journey as a woman, that I was born and then as a woman, and I wanted to give this birth to finish my cycle, the cycle of being a woman. And then, I was 33 when I birthed him, but I wanted to know, I wanted to be awake, I wanted to be not numb, and I just didn't want to have epidurals or knocked out by medicines, which after I learned, the labor is real hard. But anyway, and I wanted to witness how my uterus that been sleeping for 33 years can do this, unfold this miracle and power in front of me. I wanted to follow my heart, and I thought of home birth from the beginning. I had a friend of mine who gave a birth at home, and her midwife moved out because I guess it's a Georgia nature of it. But anyway, I remember seeing her baby when the baby was born, 2 days old, and it was just so clean and serene baby that was just sleeping so cute like this. And that was something I never seen in hospital birth babies. So that's one thing I wanted to do, but I thought of how the nature in Georgia, the politics, and also my family, in-laws, I just got married, I don't want to give a bad impression to my family, and so on, so on. So I started going to one of the big hospitals. It's called Northside Hospital, I think you may know. And I went there to start my prenatals, wanting that I will give a natural birth, but, no medical interventions. I thought that will make me happy and make my baby happy. My in-law will be, thank you. And but when I was there, I have to change MD and CPN for 4 times, because one time I went there for the first day, I met a doctor that was recommended by a GYN doctor of mine. She had a wonderful, brilliant resume from Emory University, sparkly, and she dressed well, carried herself professionally. But when I told her about birth plans and how much my heart aching to give this baby the best birth, she was just dismissed it. She said, like a birth, I said, I want to have a plan for birth. It's called birth plan. And then she said, forget it, girl. Almost like basically she said, she's a professional one, and I never gave birth before, so who knows? Nothing will go as planned. So she dismissed my idea. And I felt disrespected. Also, I felt disrespected because she had these plastic nails. And in my opinion, sushi chef and the doctor, OBGYN, who touched this delicate area shouldn't have a plastic nail. And I thought that was a very insensitive thing for her to do. Like, she's a woman, doesn't she know how it feels like, excuse me, with the nails? So I said, woof. No, thank you. The next person I saw was CP, certified nurse midwife. She was about 20, Paki, very nice. I said, I want to have a natural birth. She said, that's great, that's cool. And but then when I talked about, so what happens if I go 1 week after due date? She got really feisty with me, and just to tell her that I want to have a non-stress test to see if it's safe to give a birth 41 weeks. Then I will do it. But then, I asked her, do you have any numbers that support you that 41 weeks is the number? Because I have a friend of mine gave birth 37 weeks. She didn't finish a baby room, but anyway, she had a baby, and it was 8-pound baby, healthy. So they were very so different. But then, why are you doing this? And then it got very comfortable. It gets terrified, and then I was very disappointed, because in the office I saw this little sign saying, if you want a natural birth, go midwife. So I went to the midwife, and I was told this policy, and I was so put off by that. So I went to a different doctor in the same clinic, the third one, and he he was the chief OB at the doctor at the clinic. But then he told me that, I really want to make sure you are on the schedule because this is like a Hartsfield airport. You're like an airplane waiting to take off. So I was like, what? This is my birth. Why are you doing this to me? And also when I was 20, I met him when I was 22 weeks pregnant. He has this old checklist, like one thing, circumcision, do you want it? No, I don't. Okay. Do you want C-section? I was like, what? I just told you I want to have a natural birth. And do I want to have a C-section? Are you listening to me, doctor? I have to wait for like 2 hours or 1 hour to see him. In 5 minutes, he's very like easygoing person, but that made me feel very uncomfortable also. And then I start feeling that being at the clinic means even though I'm seeing a doctor as a person, they just talk from their policy that they don't want to be sued, they don't want to be da-da-da. Then my chance came by as a disguise of crisis. My health insurance, Kaiser Permanente, dropped my POS plan. So in my second trimester of my pregnancy, they dropped my POS, and they basically said, well, if you want, you can change to HSA without pregnancy plan and pay everything out of pocket, or HMO and then come to our facility. But knowing the Northside Hospital has been the premier hospital in Georgia, I know I'm going to be very disappointed. So I contacted my friend again and asked her several names, and luckily Debbie and Claudia were able to take me in 6 months pregnant. And it was so wonderful to meet them. I told her how I feel about giving a birth, as I feel how the birth is a natural thing, and then I really concerned about Kai's health and like my journey as a woman. And they said oh yes to my birth wishes, and all the attention I got, like if I go there for an hour, I got all the answers being answered. And also even in a really hard one, if I ask, I'm sure the same question to the certified nurse midwife in the hospital, she will shred me to the pieces. But like for instance, like questions like what happens, like how much baby died as a home birth also, because like my husband is a warrior and also his mother is, and what about if you are going to have a heart attack and so on and so on. But then they never took it personally, like the doctors, like those midwife did, and they always answered questions very calmly, professionally, and then I finally felt that I was in a very, very good hand. And so making this decision of giving a home birth was not an easy. I'm sorry, I'm more than speaking 2 minutes. Blah, blah, blah.
You will wrap it up, though, right?
Yes, I'm wrapping up right now. I'm sorry. That's not the easy one because this is not legal yet to do. And I don't do anything illegal. I'm very responsible citizen, and I didn't, like anything that breaks the law, I feel very uncomfortable. But like when I followed my heart, that was overwhelming reason of choosing a home birth. So here I am here asking you all to support this cause. And I wish, like other women who wants to have a home birth, but because this is not legal to do, and then like hesitating to be able to go to home birth options. Thank you so much.
Are there any other persons in the audience who would like to say anything? And then I'd like to ask the final comments from the committee, and then to just also announce that the next meeting will be Thursday. I think that's Thursday. It's Thursday, December 14th, same time, same room. All right. Is there any other discussion from the audience? So I would like to thank the audience. The testimony was excellent today. I really do appreciate it, and I appreciate the respect that everybody has given each person. Even though we didn't have a formal plate, like you have to hold your hand up, everybody was still respecting each other, so we do appreciate that. Any closing comments from any of the members? Good to meet you, Dr. John, and always my distinguished colleague, Representative Shelton, I do appreciate you, and then Niles, we appreciate the work you've done in the community for a continuous time of years. And Debbie, I do appreciate the way you've sort of just come in and sort of filled in a lot of dots for us. We do appreciate your work as well.
One thing I do want to say is that home birth is not illegal in the state of Georgia. It's just in order for families to have a midwife with them, a direct entry midwife, that's where it's not illegal for the families. So I think it's real important that they know that. Thank you.
I think there were a lot of salient points brought up today. Your points, especially Susan, about when you get physician input and backup involved, that's going to be one of your biggest legislative headaches. I suspect that you'll overcome. Also, the malpractice issues will always terrify physicians, for the most standpoint. When the obstetric textbook that we learn from has 38 chapters on complications and 3 on normal birth, you know how the residents are trained. But after 30 years of delivering babies, older physicians can be a lot more calm with the average type of delivery, which is where I am at in my career. I allow a lot of deliveries with no IVs, no monitoring, the Bradley sort of method deliveries. I just work with the patient, doesn't bother me. It terrifies nursing staffs, it terrifies hospitals, and so it's I'm not really out on a limb. I don't worry about it because I have my own confidence, but there is a lot of work, and I'm here to give you as much opinions as I can. I think you will find a fair amount of resistance in the medical community for no other reason than they just don't know what a trained midwife can do on the outside. And it is true that midwives that are currently working in hospitals under the auspices of us as physicians pretty much turn into the doctor-type midwife. They have to do everything by the way the hospital protocols are, and they literally, I've watched very natural, lovely midwives turn into medical machines after about 8 to 10 years of hard work in the hospitals. They do get sort of, not a brainwashing situation, but they just have to learn to do it, the way. And the number one detriment to natural birth in this country is epidural anesthesia, and until this country decides that they want to enjoy their birth and the pain that comes with it, women of all ages and races and ethnicity will always love an epidural. It's the Cadillac, and it is the number one reason our C-section rate will reach 50% in the next 10 years.
All right. If there's all hearts are clear, we'll join. We'll see you next Thursday, December 14th. Thank you very much, and God bless.